speaker is Dr. Shalin Shah.
Okay, so I have a few cases where I had a benign lesion and a malignant lesion. I mean, two separate cases who presented in a very similar way. So I have no financial interest. So we directly go to our cases. So first, we had two young male patients who came to us. History similar, red eye since 3 to 4 months, a painless mass, progressively growing, no history of bleeding. So these were the two patients, case 1 and case 2. So case 1, we see that there's a large white lesion. Otherwise, there's no redness. In case 2, there's a large congested lesion, and the entire ocular surface is congested with hyperkeratinized area. So the case 1, who had a left eye mass, examination showed that, examination of the other eye showed congestion in the right eye as well. So this was the left eye mass, fungating mass growing on the temporal side, abduction deficit present. And in the right eye also there was congestion and a flat mass growing on the temporal limbus less than 1 clock hour in size. And as we can see from the face of the patient, it was a patient of xeroderma pigmentosa. Whereas our second patient, a unilateral mass growing in the right nasal side, and it was a blind eye. He had a history of trauma, loss of vision some 15 years back, and a query history of a retinal surgery, no definite records, and a USG showed disorganized contents, probably treated as an RD, a failed RD surgery was done. So this was a conundrum for me, that how to treat both the masses. The first case was a definite OSSN in a xeroderma pigmentosa case, whereas the second one very much looked like an OSSN case. So we did an impression cytology. First one showed definite neoplastic cells. The other patient showed desquamated atypical cells and inflammatory cells, but it was not conclusive. So we went ahead, first case, we gave them neoadjuvant chemo for reduction since MRI showed invasion of the lateral rectus insertion. And in the second case, we went ahead with an excision biopsy of whatever visible tumor was there. And when we excised, we had an exposed scleral buccal underneath, which was the reason for such a presentation. And the histopathology came out to be a pyogenic granuloma. And this was the explanted scleral buccal in the same sitting after excision. And the patient was managed conservatively with topical steroids. And after 1 month, the entire congestion, hyperkeratinization, everything disappeared. The first patient is still undergoing his neoadjuvant chemo, so I don't have his follow-up right now. So this was our first conundrum, an OSSN versus a pyogenic granuloma due to an exposed buccal, both presenting in a very similar way. The one difference that sentinel vessels I should have spotted in case 2 if it was an OSSN, but it was a diffusely congested mass, diffusely congested ocular surface, so there were no visible vessels as such, dilated vessels. Now cases 3 and 4, both were elderly patients, 1 male, 1 female, complaining of unilateral watering with redness over 6 months, and there was some whitish discoloration along the lid margin. So they were first seen by a general practitioner who told them it was vitiligo. Then they were referred to a comprehensive ophthal who noticed a white mass in the fornix. And so these were the two patients. The first patient was a male patient. Only in the left eye, there was discoloration of the lower lid margin and some involvement along the upper lid punctum as well. And the other patient, we can see there is a large mass with an ectropion. So for third case, the male patient had no ectropion, lag of thalamus. The tear film was normal. And the fourth patient had severe ectropion and a history of cataract surgery. There was severe dryness and frequent touching of the eyes. So these were our cases. So we went ahead with impression cytology. It was inconclusive in both the patients. So we went ahead with an incision biopsy. The first case, it showed carcinoma in situ, squamous cell carcinoma. Whereas the second case, there were no atypical cells. It was just hyperkeratinization. Now, what was my conundrum in the case 4? Here we can see with the green arrow, we can see some atypical blood vessels which we see on the surface of an OSSN. The rose Bengal stain did not really show any result, but the blood vessels were kind of a red flag for me, so I went ahead with a biopsy. And so we went ahead with a neoadjuvant topical chemotherapy for chemo reduction in the third case, since it was involving the lateral canthus, medial canthus, and the upper punctum. And the other case, we went ahead with a conservative management with lubricant, since the patient was not ready for a surgery. It was an 80-year-old female, actually. So at 1 month follow-up, the patient is undergoing treatment. The tumor load has decreased. There's a symblepharon developing in the inferior fornix. The patient doesn't want surgery right now, since he's also noticing a decrease in the tumor size. And the fourth patient who had a exposure and keratinization, on conservative management, the size of the lesion has decreased and she is also on follow-up. So again, a conundrum between an OSSN and an exposure hyperkeratinized conjunctiva. And our last case was an elderly male, around 70 years. He had a left eye painful swelling since 6 months. Uncontrolled diabetic hypertensive. The fellow eye had good vision, 20/40 with moderate NPDR and CSME. Now the involved eye, left eye, he had lost vision 2 years back. He had some history of vitreoretinal surgery and silicone oil removal. The indication was not mentioned in his discharge card, but he said it was some retinal detachment. And after that, he had presented like this since 6 months, painful proptosis, and he was being treated as endophthalmitis, panophthalmitis, and a typical finding was a inverse hypopyon or a hyperoleon. But since an SOR was already done, such a large inverse hypopyon should not have been seen. So we went ahead with a scan, and a CT orbit showed a unilateral mass in the orbit extending along the optic nerve. The other orbit was fine, and the CNS images were also fine, no CNS lesion. So we went ahead with an AC tap, which showed us atypical lymphocytes. Subsequent incisional biopsy from the orbit showed a non-Hodgkin's lymphoma, DLBCL type. Patient was HIV negative and no nodes, no CNS lesions. Unfortunately, the patient, after the second surgery, met with a road traffic accident, was admitted for around 15-20 days, and we lost the patient. So it's an unsolved mystery for us, whether the primary surgery was because of an intraocular malignancy, primary vitreous lymphoma, which then spread to the orbit, or it was an orbital lymphoma, which had an intraocular extension. So, thank you. Thank you, sir.
Very good collection. The scleral buckle.
Yes.
And we named it as a dragon in the eye.
Okay.
Because back in the days, like people in rural area, they are not aware of what being done on their eyes.
What is being done in their eye,
and
exactly.
After the vision is lost and it goes into phthisis and all. And it gets
forget
infected,
a follow-up that anything needs to be done. Exactly, it was a similar case, and the parents also had no idea what was done. They just had history of trauma, and some surgery was done. So we did not suspect a buckle, but yeah, it came out to be an exposed buckle which was causing everything. Thank you, sir.
Any questions, audiences, please?
Yes. Sir, I did not put them, but if you would like for academic interest, I should have put them. Sure, sir.